come on in. Okay, so guys, this is the fibre optic intubation session, okay? So in our service, there's 3 holes we're going to go through when we're managing someone's airway. What are they? 3 holes. The mouth, okay, so 99.2% of our cases are going to be oral intubations as an RSI, okay? What's next?
Nose.
The neck is next. Thank you. And that's when we've really gone to pot and we've got to do something about a surgical airway. The next one is the nose. And these are the inter-hospital type patients where we've got time to be able to manage them. They've had a predicted clinical course where they've been on CPAP or sitting on a Hudson mask for 6 hours. We've got time to plan it and work it out. We've got time to assess their airway, and these are known difficult or anticipated difficult airways. We're going to need to do a fibre optic airway. So there's all of that stuff in our kit works together, and works together for a reason. There are cheat sheets in there, and there are dose cards and all sorts of things to be able to identify what things you can use together and dose limits for local anaesthetics. And if you're not familiar with the kit or you're not happy and you want to discuss it with someone, you can always bring the SRC, the Senior Retrieval Consultant, on, because these cases you're going to have time to talk about. Okay? So moving on from that, there's 3 types of drugs that we're going to use in preparation for this procedure. What are the 3 types of drugs? Okay, local anaesthetic, or the broad topic is topicalization. So in our kit, we have lignocaine, intravenous preparation to be able to use for topicalization when we're spraying it through the scope, which we'll talk about in a minute. And we've got cofenilcaine. This is a local anaesthetic and vasoconstrictor combination. Has anyone had that sprayed at them or on them or in their mouth? How does it taste? Like poo. Okay, it is awful. It is awful, and you need to warn your patients that it's going to be awful. Because part of the thing about awake fibre optic intubations is the first word is that the patient's awake. And it's about gaining their confidence and keeping their confidence. And if you spray this into their mouth without telling them it's going to be horrible, then you're already behind the 8 ball in terms of the rest of the procedure. I'm sorry, this is going to taste awful, it's really horrible. So what I'm going to do is I'm going to spray the nose, and I'm going to go back further into the back of the nose. And if possible, some people like spraying the back of the throat. You just have to be aware about your total cumulative dose of local anaesthetic. Now, when I say use the stuff in the kit that we provide for you, it's because you might do this in any hospital in New South Wales, but you're in a hospital. So if you've got your own recipe for some of the topicalization, you can add stuff in if they have it available at the hospital, if it's appropriate in the pace of your normal experience, okay? The rest of the equipment, I don't want you to MacGyver up stuff, I want you to use the equipment we provide you, and we'll talk about the reasons why in a minute. So if you like to use lignocaine and adrenaline nebulized, fine. I don't think it makes much of a difference, but it often makes you feel as though you're doing something in the meantime while you're setting up the rest of your kit. What I would also tend to do is if they have some lignocaine gel, I put it on the round without the outside of my nasopharyngeal, which is my portal for going through the nose. And I'll put that in the nose and leave it there. Before I put that in, I will split that nasopharyngeal in a certain fashion. I'll tell you why I split that in a certain fashion in a minute. So I put the local anaesthetic gel on that and I put it in the nose. The reason why that's not in the kit is because it needs to be stored in the refrigerator and it's just not suitable for our shelf life. Once I've got that nasopharyngeal in, I will spray through that nasopharyngeal, and if I can get, I won't leave it like that, but if I can get the patient compliance to be able to go, can you stick your tongue out for me? What that does is it brings all that anterior structure forward, and if you can get them to that and spray, they usually cough at that point. It's okay, sorry. It will go straight onto the vocal cords, almost universally. If they then develop a hoarse voice, jackpot, it's even better, okay? So I'm going to leave that while I'm setting up the rest of the kit. I'm going to have some pre-oxygenation on. I might cut off half of a Hudson mask or a non-rebreather mask. If I've got nasal prongs on, I'll put one up the nostril so that's ready so the other nostril's patent for me to go through with my scope. Is everyone happy with that topicalisation? That's the first set of drugs we use. What's the next set of drugs we use?
Sedation.
Sedation. Yeah? Okay, we can talk about them out of order, but that's fine. We'll talk about sedation. So what are our options in our kit for sedation for these patients? There's 3, I'll give you a hint. Midazolam. Next. Ketamine. Fentanyl. Beautiful. Okay, so what are the advantages and disadvantages of each of those medications in 25 words or less? Start off with fentanyl. Advantages? It's an antitussive, so it makes them a bit cough suppressed. It's well tolerated hemodynamically, but to get them really sedated, you might need high doses, and then the risk is apnea. Now, the natural enemy in terms of your safety reservoir of time is spontaneously breathing patients. If they become apneic, then your time frame is out the window and you have to be much swifter and quicker at what you're doing. Midazolam. Hemodynamically stable.
Anxiolytic.
It's anxiolytic.
Amnesic.
They don't remember the horribleness that you're going to do to them in a minute. The big problem with midazolam, though, is there's a very large inter-patient variability. So I can give you one of midazolam and you'll sit there and go, hey, that's cool. And you give me one of midazolam and you go, when are you going to give me some drugs, doc? And you give someone else in the room one of midazolam and they'll be unconscious apneic. So you just have to be careful about midazolam, and especially in combination with other agents in terms of central nervous system depression and apnea. The next drug is ketamine, and ketamine's wonderful. One of the other groups said, do you worry about dribbling? In the doses we use, we almost never see it. In the grams and grams you use in developing countries for orthopedic operations, they do dribble a lot more, but in the smaller doses we use, we just don't find it occurs. But the problem with ketamine is that they become less compliant with when we want them to do things. So if we say, can you stick your tongue out? They won't be able to do that. So you'll have to get your airway system to grab some green gauze, pull the jaw forward, or grab onto the tongue and pull the tongue forward to assist it. Okay, is everyone happy with that? So you can use combinations, but be careful of the side effects. So sedation will help you. The last set of drugs is something to dry them up, an antipsychotic. In our kits we have atropine, intravenously dosing, quick onset. The side effects are of course tachycardia, and it might cause rate-related ischemia in the older patients that we have, so you just have to be careful about your dosing. And across the blood-brain barrier, so it can make some of the older people cognitively impaired. If you're in hospital, you can use glycopyrrolate, doesn't cross the blood-brain barrier, and it's quick onset and has less tachycardic effects. But they come in glass ampules and they just break a lot in our kits, so we've removed them, okay? So they're the 3 drugs. 3 holes, 3 drugs. The next thing to think about is the positioning of your room and your furniture and your kit. So certainly you want to make the ergonomics suitable so that when you're doing a procedure you can see your screen, you have your drugs prepared and everything set up and your airway system briefed. The equipment. Now, the nice things about this stuff is it's pretty nuts and bolts, it's pretty robust, and it works. They're not your $17,000 Pentax scopes that we have in our hospitals. They're much cheaper, but they work for our purposes. The green ones are the operational ones. The red ones are the training ones. The way that they make them disposable is that there's a lifetime expiry chip in here of about 6 to 8 hours. So when you plug it in, you've got 6 to 8 hours to let it work, and then it will die. There's 2 of these in your packs, so if the one doesn't work, the second one will get you through it. And if you're on scene for longer than 8 hours, you've got to question your scene time, okay? The way they work is they plug in with an arrow into your monitor. We'll talk about the monitor in a second. There's a thin wire that goes down either side of your scope so that you can move it backwards and forwards. But that's reasonably weak, and if you're too aggressive with it, it will snap, and then you're unidirectional. Okay? There is a injection port on the Airway scope 2, which is what we've got. Doesn't suction very well. I wouldn't use it for suction. It's for injections only. Okay? Now, the monitors the company states that they're retrieval proof, but you can see that they're not. Okay? So you have to be careful with your kit. And what we designed was a plastic Perspex cover to go over the front of them to protect the screen. So they're not disposable. Please don't throw them out, and the monitors certainly not disposable. And they have a battery life, but I recommend that you plug them in, because odds on the battery will go flat at the time when you've got the view of the cords and you're about to just put your tube in. Is everyone happy so far? Okay. We're going to move over here. You can come a little bit closer. We're going to see the stuff on the screen. I put my nasopharyngeal in. If I've got lignocaine gel, I put it on the outside and I put it in. Why do I split it, the nasopharyngeal? So you can remove it in a second. Excellent. Why do I split it in a certain fashion? It's always at 6 o'clock or 12 o'clock in the clock face position. Why is that? Can anyone think? What's in the nose, on one of the walls of the nose, that will poke into my split almost every single time if I don't split at 6 or 12? A nasal turbinate. Almost invariably it will always sit into that split. So it's always 6 and 12. What I'm going to do is I'm going to position my patient, have my airway assistant briefed. I'm going to preload my size 6 reinforced tube, which is in the kit, and we want you to use that every single time. If you're short, I would stand on a box and put the bed on the floor, and then I'll do the procedure with a briefed airway system. So one of the main things about fibre optic intubation is you want to look good doing it, okay? This is not gastroenterology where we're doing this with the long black snake. It's fine finessing movements to get control. And so to do that, we need to get all of our spare loops out of the cord. We've got to have our arms up high, and we've got to use our deltoid muscles, and we've got to think of the curve, the natural curve of where we're going to be going in. So we're going to place our scope through the nasopharyngeal that's split. We're going to put it into the airway. We're going to get our lovely view, keeping in the center of the screen the whole time. We're going to get our airway assistant to come up once I've got a view of the cords. If you're happy to spray some 2 ml local anaesthetic, 2%, onto those cords, you'll see it go onto the cords. It may obscure your view. And if you get any secretions or anything on the end of your scope, I always put a pile of alcohol wipes on the chest, so I dab it and straight back in. They may cough at the point where you spray some stuff on their vocal cords. Let it give time to work. And then we're going to advance it through the vocal cords, all the way down into the trachea, seeing tracheal rings, keeping your center of the picture of the view that you want to have. I'm going to get my airway system at that point to take out the split nasopharyngeal airway, and then I'm going to advance the tube over the top, keeping the view on the screen the whole time. If I get arytenoid hang up, I'm going to rotate that tube 90 degrees anti-clockwise, and I'm going to put it in. I'm going to take my scope out. I'm going to blow up the cuff, and I'm going to confirm position with end-tidal CO2 and ventilate the patient. And then I'm going to give my induction drugs and my paralytic agent. And high five. Okay. For icing on the cake, you can put your scope back in once you've reoxygenated the patient. Have a look at the primary carina with your scope. Identify primary carina. Put your hands on the top of the scope and bring it up until you get to the level of your tube, and you know that you're that far above the primary carina in terms of insertion depth. How do we know it's primary carina? I'll steal the board just behind these guys. You know that your regular airway bronchial anatomy is that you'll have trachea, you'll have a primary carina, your right main bronchus, your right divisions of bronchus, your right upper lobe will be variable. It might come off trachea or it might come off middle lobe, but the divisions are very early. Whereas the left main bronchus in an adult will be between 4 and 5 centimeters before the first division, so that's how you know that's primary carina. Is everyone cool with that? Okay. Questions? Thoughts? Queries?
Depth of insertion? I mean, apart from directly.
Physiologically, it's best to be able to measure it from primary carina.
Yeah.
Often we tend to find that most patients will tolerate it going almost all the way in with a little bit of space, but if you fine tune it, you'll have better ability to be able to secure that. And we secure that with brown tape. Whether you do trouser legs or tape around there, it's often the easiest way to secure that. Happy?
Does the position either from behind or the front?
Okay, so
is that patient specific or
so ergonomics, I tend to find that if they're supine, it's often easier to do it in this sort of motion. If they're sitting up, self-selected because of their pathology, it might be easy to do that way. But if you've got very long arms, like big gorilla like me, you can still do it sitting up if you've got it standing on a box, like this. In that sort of motion. But you've got to have the monitor positioned with your drugs ready and your airway assistant positioned appropriately to be able to make the ergonomics easier.
Geoff, do you ever employ an assistant to do a jaw thrust or put on the tongue?
If they're not compliant, so I want them to go, stick your tongue forward when I'm getting the view of the cords. If they're not compliant or they don't follow directions, either because of sedation or refusal, generally you get an airway assistant to hold the jaw and pull it forward, or some green gauze if they're ketaminized, and you can pull the whole tongue forward. The ENT guys do all this stuff for the vocal cords, to have a look at vocal cord anatomy and pathology during nasal endoscopy. I do that just for my own amusement. Okay?
You do it on the patient.
Okay, so what I want you to do is I want you to break into two groups. I want you to get your hands on the kit, get involved, start using the stuff, develop the muscle memory, play with it, and then we're going to break off in a minute and we're going to advance this whole thing to the next level and talk about some tips and tricks, okay? So get your hands on, get involved.
Holding.
Some people routinely, instead of using a nasopharyngeal, they'll put their tube into the nose as their portal for the introduction of their scope. Now, I don't have a problem with this. I don't do it for a couple of reasons. So if you do it, just be aware of the disadvantages of doing this approach. The first disadvantage is the split nasopharyngeal always tends to sit in the hypopharynx in a regular position, and you often see the level of the cords nicely. It always just presents you with the view of the cords. Whereas if you use your endotracheal tube that you're going to intubate them with to start off with, the depth of that is going to be variable and it may not sit always in the same position. So it might be in the esophagus already by the time you put your scope in, and it means more movement. If you need to come out to clean your scope on your alcohol wipes you put onto the chest, it's further to come out and it's a little bit more dexterous to put it in, and it will move in and out, cause more nasal trauma, more bleeding. The other thing is, if it all goes to pot and you need to come back out and ventilate them because they've become apneic or they've got laryngospasm, it's very difficult to put a face mask over the top of a tube that's sticking in their nose because you can't create that seal. Whereas if you've got nasopharyngeal in, you can put something over the top of it. So again, I don't mind if you do that technique, but just be aware of the side effects or the disadvantages of doing that. Is everyone cool with that? Next, every now and again we will go to patients and they will be ventilated with a laryngeal mask in situ. Now, as an anaesthetist, a small part of me dies every time I see these because I hate them for elective anaesthesia. But for our purposes, they're brilliant. They are reasonably easy to insert, the seals are not too bad, and they have an inbuilt bite block. So they're good. But whenever we've found problems with our airway registry with doing the advanced airway stuff, it's because people have MacGyvered up the stuff instead of using the kit we provide in the situation where they've already got a different type of laryngeal mask in. And then they try and introduce a scope and a tube through that. The problem is that all laryngeal masks are not the same. They have bars in them that prevent your scope or your tube from going through. They're different apertures. And in the old days, the Pro Seal or the Supreme was brilliant, but now in the disposable ones, the airway lumen comes through and splits either side of the gastric lumen. So they're impossible to put a scope through. So you've got to get to that point where you've got your plan and your kit ready and your drugs ready and your scope prepared and your ergonomics and your furniture set, and you've got to go, because this is the oral lumen that you're going to use, not what they have in place. Okay? And then what you're going to do is you're going to use your scope with the preloaded size 6 reinforced tube, which is in our kit, and it will fit through all of our laryngeal masks or our iGels in our kit. Size iGel plus 3. So it'll fit through the size 3 laryngeal mask. We're using this stuff for adults, not for kids. And then what we're going to do is we're going to go through that and put it through with the scope, find the vocal cords and straight through. Remember, these patients are going to be ventilated, not awake, self-ventilating. Now the trick is If you MacGyver up your own system, we've found there's problems with them. If you're using a standard Portex tube available in a hospital, you can see that the distance that it extrudes beyond the tip of your laryngeal mask for your black line at the level of the cords is very small. So your likelihood of having a cuff herniation through the cords is much higher. Whereas our kit, which is purpose designed to work, your black line at the level of cords gives you much greater length, because we all know it's all about length. Okay? Now once you've got that in, and your scope preloaded, and it goes through and it's in the vocal cords, and it's in the trachea and you're ventilating, what do we do now?
Leave it in.
Leave that in. We don't exchange over the top. We've come through all the trouble of having a difficult airway and going through that. We don't have the exchange catheters and pushes like in the intubating LMAs. We leave that in. Let the anaesthetist at the other hospital sort it out. It's got an inbuilt bite block, and you can secure it as best you can. High five, you've got the secure airway, that's sort of job done. Transport the patient. The caveats with reinforced tubes are really, really important to highlight. There are at least 3 cases I've heard of where these have been used orally. The patient has bitten down on that. They've compressed the reinforced ring inside it, and they've been unable to be exchange cathetered with an exchange catheter, and the patient's had a bad outcome or died. Every ICU in the state will hate you for bringing these to them because they're very hard to suction through. The next thing is, when they come in their packets, the metal ring often has a little bit of a gap between the blue cap, and they are easily able to be kinked, especially when they're warm. So just be mindful of that. Is everyone cool with that? Questions? Hands on. Get used to holding a scope preloaded through a laryngeal mask and into the patient. Hands on. Develop that muscle memory. Go for it.
Geoff, quick question. With
Go.
nasal intubation, what size tube?
Size 6. It's in the kit. That's all we provide you with. Use the kit as it comes.
The reinforced one? Or
Yeah. Size 6 reinforcement every single time. It's the kits they're designed to be purpose-built that it works.
Tube tight.
Something around here, if you're just doing it from the